Well, thank you very much, Laura, for that. We reckoned we'd have 3 men and a dog in here this morning. I'm delighted to see we've actually at least doubled that number, so thank you for managing to get here. As Laura said, I'm Jonathan Botting. I'm a GP. I never undertook any formal surgical training other than through my house jobs, but I got involved in minor surgery through our local dermatologists, and from there the whole thing has rather exploded. And I'd like to think that, following on from what Mike said about the increasing pressures on general practice, the relative reduction in numbers compared to the increase in population, is that those of us who are at the coalface in primary care actually need a break every now and then. And the best break I have is to do what all of you do, which is to actually get away from everybody else and start operating, and that's what gives me rejuvenation every week, and it's why I encourage so many of my colleagues to try and follow in my footsteps as far as taking up minor surgery. I wanted to go through a number of things. First of all, the sort of range of provision of things that we undertake in primary care, then the rationale behind community surgery, a bit about the quality agenda, and some of what I see is going to happen in the future. Well, as far as the range of activity is concerned, what I first got into was very much the dermatology side of it. A lot of lumps and bumps surgery. And then we have the extended surgery, and this is where Laurel certainly would come in, because some of the data that I'm using today has come from her. We have an ever-increasing range of opportunities in primary care. We have some fantastic facilities, and if any of you have had the opportunity to visit practices where surgery is taking place, you'll know what I mean. We have wonderful facilities. We've invested greatly in those, and it would be a shame for them not to be used to their maximum. So in the community, first of all, looking at my own practice in Glebe Road, we undertake quite a lot of skin cancer work, and very briefly a little look at what we achieved over 3 years just looking at basal cell skin cancers. So each year, not huge numbers, but this is once a week surgery that I provide for 2 hours, but showing that we can actually, despite a lot of evidence, produce very good results. So here, everything was fully excised, but a couple of narrow excisions, and those were then reoperated on. But often elderly patients who find it difficult to go to hospital. Whenever I produce data like this, people often wonder if we're if you like, cherry picking. We're choosing the easy things for surgery in the community. Luckily, I've got some evidence to show that that's not so, because I also work in a local hospital, Queen Mary's, Roehampton. It used to be very famous for its burns unit. Sadly, it's far less activity there now than there was. But this was undertaken by one of our nurse specialists in the department without our knowledge, just looking at complications rates. And you'll see that the number of doctors down here, myself and 2 GP colleagues, and then our plastics department who come in to help run the dermatology list. So it's all the same activity. And interestingly, the range of complications was higher actually amongst the specialist group than those of us who were GPs. So I think we can provide a very similar sort of service in the community. Carpal tunnel surgery, something I don't do myself, but evidence that comes from one of our colleagues in the independent health group, and this is looking at their results for carpal tunnel surgery, and I understand that the percentage improvement that they achieve is as good as anywhere else in the UK. And so these are feedbacks from patients. And then when we're looking at their results compared to Levine's results, we see that actually they are as good as with the overall satisfaction of the service. So carpal tunnel, something that can be very easily undertaken in the community. This is from Laurel's own practice, so we're looking at different questions but very similar answers as far as complication rates are concerned. I think we can also see that year on year Laurel is getting better and better, and she's undertaking really quite a large number of procedures in the community. These are the so-called patients-reported outcome measures. Always an interesting way of looking at things. So rather than looking at our own results, actually asking the patients what they think the results have been. And we can see that year on year, Laurel achieves exceptionally good results. Hernia repair. Well, hernia repairs in the community have been going on for a long time, and we have one of our founding lights in the Association of Surgeons of Primary Care to thank for this, and that is Raj Dumali. So Raj undertook a feasibility study. This is back in 2004, looking at hernia repairs, and found that quality and safety was not compromised at all by undertaking the community. And the one great advantage was that waiting times were significantly reduced. Raj also helped found a unit called Probus down in Cornwall, and he and his colleague John Tinsdale went through some over 1,000 patients who had undergone hernia repair, and they had a total of 3 recurrences. Complication rates were similar or lower than those in specialist hernia centres, and over 90% of patients would be satisfied with the service. And the great news sort of Tory thing, would you recommend to friend and family? Again, over 90% of those going through the service were very happy with that. So hernia repairs are something that certainly can be done. Next one, another of Laurel's inputs here, vasectomy. She either seems to be snipping off tubes or looking up tubes, and this is the figures from her Tollgate clinic, 397 vasectomies, and we're looking at the clinical complication rates, and then at the right-hand side, the ASP average. This is Association of Surgeons of Primary Care, which used to be the non-scalpel vasectomy society, and you can see that the results available in the community are exceptionally good. And again, if we look at it in terms of their reported outcome measures, and excellent score and 92%, very good 7%, and good 3%. And you'll note there isn't that equals 100%, so there was nobody who was actually in any way dissatisfied with the service. So vasectomy is certainly something that can be undertaken in the community. Sigmoidoscopy, another of Laurel's one. As I said, she's not cutting it off, she's looking up it. And sigmoidoscopy is, of course, an area where you can definitely avoid unnecessary secondary care involvement if you're able to screen effectively. And Laurel's results show over a 3-year period that somewhere between a third and 2/5 of patients have normal outcomes that mean that they've avoided any form of secondary care involvement. And then the other minor conditions are ones that she can manage within the community. So actually the screening effect of her sigmoidoscopy is such that she massively reduces unnecessary referrals into secondary care. Again, looking at the PROMs there, you'll find that, again, patient satisfaction is extremely high. But then looking more at the rationale behind community service, the reason that we need to be interested is that looking at it in terms purely of skin conditions, and this is where I'm mainly involved, is there is such a huge increase in demand. So we look at the figures from 2010, around 100,000 non-melanoma skin cancers and around 12 to 13,000 malignant melanomas each year. And we've been seeing a doubling of the malignant melanoma incidence every 10 years. And we're seeing BCCs and SCCs increasing somewhere between 32 and 39% over the last 8 years. And we know that BCCs and SCCs tend to be underreported. These figures come from Cancer Research UK and also from the NCIN. We're an aging population, and this is exactly as Mike was talking about the multimorbidity. We see that not only are malignant melanomas more common in the elderly, but of course we are getting more elderly. So there is going to be yet increasing demand on surgical provision for skin cancer work. And we look at it in terms of the incidence, age standardized rates, and we see that the rate is increasing it like this. But if we look at the number of consultant surgeons, I realize it's always difficult to have direct comparisons, but if we look at the way in which those numbers have increased between 1999 and 2009, there is a disparity there. Now that increase in surgical numbers is similar to the increase in dermatologist numbers, so there's an increasing workload that needs to be addressed. I always find it difficult when we look at health economics, because trying to take into account the costs of the infrastructure and what somebody would be doing if they weren't operating is complex. And I'm looking through John Primrose's Mystic study, trying to understand the cost analysis, and I find it very difficult to do it. So I'm being a simple person, I'm just looking at actually what it costs us as GPs to either commission something within a secondary care, or what we will actually cost the NHS in direct tariffs. And we look at this in terms of outpatient procedures or day case procedures, and we see the difference between hospital procedures and the average, what we call, these are LES, locally enhanced services, or more nationally, the direct enhanced services, and it's extraordinarily cheap, somewhere between 80 and 90 pounds per procedure. And if we worked out that all the malignant melanomas and about 80% of the non-melanoma skin cancers required surgery, you get an idea of the sorts of differences between the secondary care tariff and the primary care tariff. And then if we look at that in terms of the work that John Primrose did in his article, and he was looking there at finding that the health cost was somewhere around £1,200 in secondary care and about £449 in primary care. Now, the difficulty for that is I look at that and think, well, I really wish I could identify that £450, because I know that when I work for NHS England, the London contract, it's £88 and 4 pence for each surgical procedure that I undertake. And of course, the difference between that and the mean cost, which is actually very similar to the day unit cost, is the difference between about 112 million and 8 million between primary care and secondary care. I realise those are not exact comparisons, but that's what it means to me if I'm commissioning a service. If we're going to look at primary care in the community, however, it's really important, and this is what I drive home to colleagues who wanted to take up surgery, that you've got to not only know what you're doing, but also know how to do it. So this idea of safe surgery involving not only the development of surgical skills, but also the development of lesion recognition is so important, and that requires dermatology knowledge, it requires surgical training, and that requires cooperation between primary care and secondary care, as does this. And it's one of the things I've always tried to do, is break down this barrier between primary care and secondary care. We're all doctors and we're all looking after the same patients. in order to get to that quality agenda, we've been through quite a long process in primary care. We used to have a thing called the minor surgery list, and effectively that meant that if you had once worked in an A&E department or stitched up the odd drunk on a Saturday night, you could get yourself onto the minor surgery list and take out anything you liked. Not the best way of addressing quality. Then we introduced with fund holding this items of service and cost per case, and this has led to more and more GPs becoming interested because suddenly money was following activity. Then Primary Care Trust came along, and the Primary Care Trust started holding the contracts. This was a huge variation because it meant that they became responsible for where the contracts would be held. And in 2006, we had the Improving Outcomes Guidance for Skin Cancers, and this is where one of my colleagues I work with locally, Barry Powell, was once heard to say there's no place for the care of pigmented lesions in primary care. Now, that to me was a time to a wake-up call that we needed to be able to get our own house in order and to prove whether or not we really could look after complex skin cancer. We then developed the approved doctors for low-risk BCCs. This was when NICE reconsidered taking out all skin cancer work and put low-risk BCCs back into the community. And with that revision in 2010. And that meant that all GPs could, in theory, undertake skin cancer work for low-risk BCCs, but some were more equal than others because those of us who were GPs with specialist interests could undertake a little bit more. Since then, we've had a Department of Health guidance on GP minor surgery, guidance that I was involved in bringing together, and this is looking very much at the quality agenda. And from all of that, we then get to where we are now, and what Imran will be talking about is the commissioning importance. As far as the next stages are concerned, NHS England has introduced commissioning, and this is being undertaken as a trial in London at the moment, and it's a new enhanced service contract, and it's at 3 levels. Level 1 is simply injections and aspirations. Level 2, some invasive procedures, including excisions, and level 3 is when we start getting into skin cancer work. So these are for GPs who do not have a specialist interest, but have a desire to be able to provide a service. And in order to do this, they have to be accredited, and we now have the framework in place to ensure that any of the GPs who are undertaking this will have their accreditation in place. And you may hear locally of GPs wanting to undergo directly observed procedures to show that they are skilled at what they're doing. And we have to undergo the National Health and Safety and Infection Control Standards. So what we've been left with, unfortunately, from the Improving Outcomes Guidance is a rather complex field in which we can operate, particularly when it comes to skin cancer work. So we have to look at, first of all, low-risk BCCs, and then are we available for the directly enhanced service, and then are we confident it's low risk, and then in order to work out if it's low risk, is the patient aged 24 or under, are they immunosuppressed, is it below the clavicle, is it above 1 centimetre or below 1 centimetre in diameter, is it recurrent or non-recurrent, is it high risk type, is it located in a high risk area. It starts getting very complicated, and then you look at the other group of us as GPs who are the Model 1, what we call GPs with specialist interest, and we have a similar pathway, except we can go above the clavicle, but we're not meant to go in certain areas, and we can go up to 2 centimetres below the clavicle or 1 centimetre above the clavicle. It's a very, very complicated field that we've introduced, and it's to no one's great benefit because we then spend our lives trying to work out whether or not we are or are not meant to be able to do this. And in my own case, if I don't do the surgery, we send it up to our local unit, and then I operate on it in the local unit on my own instead of in the general practice on my own. So it's a very complicated system that we've introduced that I don't think works particularly well for anyone's benefit, because it introduces all these different steps and it produces tensions between primary care and secondary care. The latest guidance is the one that I mentioned I've been working on, which was the for competencies and provision of services. And this very clearly states what we expect both GPs with specialist interests and those undertaking the directly enhanced services to provide in the way of evidence. And it's all about quality. And it either requires large volumes and enough to be able to produce audit outcomes, or from observation. And so we've actually put into this the fact that you really need to be able to demonstrate that you have the skills necessary for the activity you're undertaking. And as far as producing that evidence, well, we can produce it personally or we can produce it professionally. The personal evidence is something that has been happening more and more recently. And these are the ideas that new practitioners are going to be able to show that they have developed these directly observed procedures, and existing practitioners either through the provision of directly observed procedures or with regular activity and auditing of that activity. So we're beginning to produce a system that is more akin to that that's existed in secondary care for a long time. As far as the personal evidence is concerned, if we look at things in terms of complication rates and infection, dehiscence, incomplete excisions, all of those are now meant to be part of the reporting structure for our contracts. As far as directly observed procedures are concerned, these should ideally be a one-to-one by a very trained examiner and standardised. And I'm working on the way in which we may be able to standardise that so that we ensure that we all try and assess to the same level. As far as professional evidence is concerned, well, there's been a lot of published data, but it is of a variable quality. And I know that Professor Murchie, is a GP in Scotland, has produced a number of articles over the last 5 to 10 years. He has a huge data set there that he's been analysing. And one of the ones that he did, which was in the British Journal of General Practice back in February 2011, was looking at some 1,200 malignant melanoma patients. And the number that were operated in primary care, there was no statistical evidence of any difference in surgical outcomes between primary care and secondary care. We then looked at survival after melanoma, and this is from 1991 to 2007, and this was looking at all of those who had been diagnosed and operated with malignant melanoma, and he could find no difference between primary care and secondary care, although those that had been operated in secondary care tended to have far more in the way of hospital attendances and outpatient attendances. He's also looked at SCC surgery, and again found no significant difference. And the problem with this is that, of course, we lead to lies, damn lies, and statistics. And when you start looking at the evidence that is out there, it does seem to depend upon who's undertaking the investigations, because GP studies seem to show GPs are as good as, if not better, than their colleagues. Hospital studies always show that hospital care is better. But then if we look at the systematic review that took place in Chicago of 32 studies, they could find no real difference between primary care and secondary care. And I think one of the problems here is that we're looking at particular aspects of care rather than much greater evidence that is required, so numbers that are required. And that's where I get onto my audit that we're trying to run nationally. And these are some of the studies that have been there, and one looks at the numbers. The numbers often are not very large, but you look down on the side and you can see that, interestingly, if the study takes place in secondary care is always better. If the study takes place in primary care is always just as good. And I'm not sure what we're to make of this, other than we need more evidence. And so looking ahead, I think we need to certainly ensure that we have advanced training practices in the community, because if we are intending to train up GPs for surgical services, we need to be able to ensure that they have that training where they're going to be delivering it. I think we're looking towards the development of educational provider networks, and this is this idea of hub and spoke. And the interesting thing is which is the hub and which is the spoke here, because certainly within our own practice area, we're looking to see how we may be able to incorporate secondary care training into the community. And I think if that increases primary care, secondary care interface, that has to be a good thing. And then the idea of delivering a seamless service. Well, this for me has always been what it's about, so that patients who come and see me in the community would have the same service as they would with a colleague in secondary care. So in conclusion, I don't think it should be us and them. It should be all of us together. And it's very much, as John Primrose said in his article, The Mystic One, it's the right person in the right place. It doesn't really matter who it is or where they're operating. What it has to be is that they are the right person for the job in hand. And I hope I've shown you enough evidence to show that GPs with the right skills are able to provide an excellent service in the community. But it also shows you the opportunities that are available for joint working between primary care and secondary care, and the work with people like Raj Dumali, which involves skills coming out of hospital into primary care. And I'm sure that's where some of our future lies. Thank you.